mental health reentry program for incarcerated individuals with serious mental illness. Dr. Henry Ireys is a senior fellow at Mathematica Policy Research. He has extensive experience in the evaluation of local, state, and federal programs designed to enhance mental and physical health outcomes for adults with mental illnesses. And Seth Prins is a policy analyst with the Council of State Governments Justice Center working on federal benefits projects. Now I turn it over to Bob Mann for his presentation.
Thank you, Elizabeth. Let me do a brief overview of the presentation. Trying to advance this slide here. Okay. There we go. I'll be starting off, and I'll be discussing Oklahoma's dramatic increase in offenders with mental illness, and then doing an overview of the program that we implemented in 2006 to enhance discharge planning for individuals with serious mental illness, and discuss the Medicaid process. Dr. Ireys will discuss the evaluation of the program and the implications of the findings. Seth Prins will do a presentation on the Justice Center federal benefits tools, and then Ms. Meyer will be facilitating the question and answer period. Oklahoma is like many states, experiencing a dramatic shift in individuals with, I think in the 1960s, the closing of a lot of the large psychiatric hospitals in the nation. We're certainly not unique in that. In 2005, PBS on the Frontline Presentation to Asylums, I think, well documented that issue in Ohio. In Oklahoma, we certainly saw a reduction from about 1960 to the last large psychiatric hospital closed in 1998, and so we saw, it was about the same time when we really saw a shift of individuals with serious mental illness coming into the correctional system. From 1998 to 2006, there was a 19% increase in our general population in the Oklahoma Department of Corrections. But during that same period of time, there was a 289% increase in the number of individuals in our system who were on psychotropic medications. I might also add that during that same period, our cost for those medications increased by 1,500%. And so we certainly saw a tremendous increase in the volume of folks, but also the acuity of individuals coming into our system, and recognized that there was a need to provide community-level treatment inside, but also had to really look at what sort of discharge planning activities we needed to accomplish. In 2008, we discharged, Oklahoma DOC just discharged approximately 8,500 offenders who were discharged to probation and parole or directly to the street. We estimate that 1,000 individuals that discharged during that time had symptoms of or currently in need of treatment for serious mental illness. A little bit later in the presentation, I'll be discussing how we identified a subset of that population, or those folks who had the highest level of need and had the most disabling serious mental illnesses. Just a little kind of demographic breakdown of the individuals who we have in our system. As of February 2009, about 50% of our population were folks who identified as having some sort of history of or currently exhibiting some form of mental illness. And as you can see, there's a disproportionately large number of female offenders in our system who were identified as such. And unfortunately, we are the state that is identified as having the number one in percentage of incarceration of females per capita. But the male offenders are also fairly well represented. And so overall, of our population, about 23% received treatment for serious mental illness or needed it and refused. And approximately 19% of our population is taking some form of psychotropic medications. So how to respond? Collaborative efforts were needed to better plan, but really, in the early 2000s, there were some initial efforts that were going on. There was a mental health and criminal justice conference that happened in Oklahoma. There were some, like I said, intermittent agency discussions of what's going on. In 2004, the Mathematica was funded by SAMHSA to come in and work with Oklahoma to design, implement, and evaluate a system whereby offenders with a serious mental illness, disabling serious mental illness, would be pre-approved for Medicaid. And so we started a steering committee that at that time go into more detail about that, but it was really getting people. It started off with a real executive level buy-in and representation, but then there was a large group of folks who started working on stuff, and I'll go into more detail about that. Other things that were going on, and I'll go into detail about this, is the Oklahoma legislature in 2006 funded some positions that were fairly unique positions, and I'll go into discussing that in a minute. But then also, we had regular interagency meetings, and interagency agreements were penned. One of the more unique ones was actually a information sharing agreement between the Department of Corrections and Department of Mental Health, and one component of that is such that the DOC mental health staff are actually credentialed to utilize a web-based interface to access a treatment summary of any state-funded treatment that is in the system over at Department of Mental Health. And so we have the agreed-upon data points that we're collecting from there are things that we feel are helpful for continuity of care within our system, but also help with discharge planning. And so, looking at the individual's past treatment history, what their employment status was, what their housing status was. And so this is information sharing. It was a direct result of all of the different projects we've been working on together. With the project, with what we've been working on with Mathematica and SAMHSA, we really had at the table some key stakeholders. Certainly, the Department of Corrections was well represented. Like I said, these all started off with executive level. All the agency directors started off, in the meetings with these individuals, and really empowered those folks who are working for them to continue this work forward. And with our Department of Mental Health, we were very fortunate in the main individual who was kind of spearheading the effort on their end had been someone who had just come off doing a very successful implementation of the PAC program for the Oklahoma Department of Mental Health and Substance Abuse Services, and so had a proven track record. Individuals from the Medicaid agency have been part of this process the entire time. Also, folks at the Department of Human Services, the folks who actually do the Medicaid applications. The Social Security office here in the state, but also the regional office down in Dallas was very instrumental in getting this going, and very positive members of this. The Disability Determination Division of Department of Rehab Services, and these are the folks who actually look at the Social Security applications as they go in, and the psychologists there rate basically, our staff send in the application, and these are the folks who determine the disability. And the collaboration that we've had with this agency has been really remarkable, where we've had meetings where our psychologists and psychologists there have met and have discussed language and discussed really, when we say someone's working, how do they define it? So we've really worked on kind of data definition. Dr. Ireys will be presenting after a while the kind of the tangible results of that. Other I think, very important stakeholders is we early on met with offenders who were in our system, but also those folks who are in the community who have a serious mental illness. And the ones who were out in the community, we were talking to them about what worked and what didn't work. And with the individuals who are still incarcerated, really talking about the same thing, what worked and what didn't work, what level of support did they need, what sort of programmatic needs had they had, and all the sorts of issues that they maybe had dealt with when they were leaving. So we worked on a model program at our 3 facilities that have a mental health unit. The Oklahoma State Penitentiary is a maximum security men's facility. Naval Bassett facility is a women's facility, and then Joseph Harp is a men's facility. And that houses our largest mental health unit. And the mental health units are essentially small encapsulated mental health facilities within the prison that have a full multidisciplinary team. The discharge managers, the funding that the legislature funded initially as a special appropriation for half a year, and then since that time the Department of Mental Health has incorporated in their general budget, was for 3 positions that are discharge managers, and these are Department of Mental Health employees and their central office employees who are based and function within the correctional environment. And like I said, they have credibility with DOC and the community mental health staff, but really beyond credibility, they have, I believe, some clout because they are central office employees. When they're looking at linking folks to services in the community, they represent a funding source, but also a regulatory source. And really, the Department of Mental Health is certainly seen as the voice of and the agency that administers mental health services in the community. And so it's really the meta-communication there is that these are individuals, and this is an agency that has taken ownership for the discharge planning for these individuals. The discharge managers receive the training. They're fully trained as if they are DOC employees, in addition to all the training that they have as Department of Mental Health employees. They did go through the SOAR training, which is the SSI, SSDI Outreach and Recovery Training, which is mostly it's for working with homeless individuals with serious mental illness to try to expedite the Social Security process. So in addition to that, we actually had a module where, in addition to learning about SSI and SSDI, they also learned about the Medicaid process in Oklahoma, so that they were actually receiving training from the Department of Human Services and the Healthcare Authority folks on how to expedite the federal benefit application process. And then the discharge managers also have flex funds available, a small amount that they can use to assist offenders with needs. The discharge managers also have access to information from both systems, but also to the information system, so that they have access to our offender management system, but also to the Department of Mental Health data core, and so that they're actually able to have a full range of and really a level of access that is unprecedented. The discharge managers function as a member of the facility's interdisciplinary team. They're really the folks who coordinate the discharge planning, but they're also working with the offenders. They're working with a particular psychologist. They'll coordinate with that person, all the planning that has to occur. They're interviewing the clients to really, work on recovery-oriented, strengths-based, looking at what their needs and their resources, really making sure that it is consumer-directed. The consumers, offender consumers, for the first time, have actually been asked what their plans are, what their hopes are, what their dreams are, but really positive, logical, reasonable steps are made towards that. The discharge managers collaborate with community agencies to make sure that the appropriate level of care, whether it be adult case management or a PAC team. The other model we use is an additional funding that was received by the Department of Mental Health was for reentry intensive care coordination teams. And these are teams that are, as of right now, based in Oklahoma City and Tulsa, so our 2 major metropolitan areas, and they're comprised of a certified case manager, but then also a recovery support specialist, and that's an individual who has lived experience with mental health and or substance abuse, and in some cases, there's one of the teams that actually their recovery support specialist is an individual who has lived experience with a serious mental illness, has a history of addiction, but also is a formerly incarcerated individual, so that when this individual goes in and meets with the offenders, they're able to speak at a peer level that in many, the professionals are certainly not going to be able to do so. The discharge managers also will, if the offender consumer is going to be going on any sort of probation or parole, they will actually link them to a specialized caseload, and there's an officer who actually works as a part of the team in the community. Back to the reentry teams, to the RICA teams, real quickly. What they are able to do is they actually come in and meet with the offender prior to discharge, and they're working with, trying to go in and engage a number of times. The first time someone comes in to visit someone in prison, they may be seen as kind of quote unquote the flavor of the month, but it's actually the engagement and the subsequent visits, and luckily with having some success, and they've been able to build a reputation where these are people who come in and really care, and then they work with the offender prior to discharge. So the discharge manager is working with offenders to make sure that we get them. In Oklahoma, you actually have to go through a Social Security application prior to being able to do a Medicaid application. So, and in the appendix, there's a flow that shows the time frames that we have to do that. But we go ahead, and the discharge manager is getting the Social Security application in. Our psychologists are working on the documentation that they need to get for the disability determination. And then as we get closer, go ahead and do the Medicaid application. With all these agreements, one of the things is that Social Security and Medicaid is still not, you cannot have that while you're incarcerated. So what we do is a pre-application process. And then on the day of discharge, we actually send a certificate of release to Social Security and to Medicaid. And essentially that flips the switch. Anecdotally, we've certainly seen successes that we haven't in the past. Even some of the most jaded correctional staff have seen successes. There have been some individuals who have discharged and actually have been successful in the community and are working on volunteering with our folks who are out in the community. And these are folks who in the past would sabotage, and admittedly would sabotage their discharge because they were so afraid of what was out there, because they didn't know about whether housing or continued treatment. And the discharge managers and the reentry team certainly work on trying to make sure that they're that the housing needs are taken care of, and that they're able to live a life of recovery and live a life in the community. And I think I'll go ahead and hand it over to Henry at this point.
Okay, well, thanks very much, Bob, and hello to everybody on the call. So we really had the great good fortune here at Mathematica to obtain a contract from SAMHSA to provide support to Oklahoma, and especially to provide support to the terrific leadership that Bob Mann provided to developing the program that he's just described. And I can tell you that he didn't really pay me very much money to say that. And in addition to providing the support to Bob and his team out there, we also had the responsibility for leading the evaluation of this new program. As I'm sure many of you have experienced, the process of getting a new effort up and going is itself intense, and then there's lots of implementation challenges related to getting a new program going, and then everybody wants to know, is it working? So we had the opportunity to work with Oklahoma and implement, and in addition to providing support to them around the intervention, to implement an evaluation and really answer the question, did the program work? So we focused on one particular component of the intervention, which was to enhance access to Medicaid for participants who were in the program, that is, eligible inmates who had serious mental illness who were leaving the 3 facilities where the discharge managers were placed. And I'll say a little bit more in just a minute about why that was an important question for the evaluation focus. In addition, we wanted to know, okay, well, it's one thing if they get Medicaid when they leave, do they in fact use more services, presumably mental health services, that they need once they've left? And the long-term question, of course, is, does the program reduce reincarceration? Now, I'm going to present information on the first 2 questions. The third question is something we're still gathering information about. Oklahoma is still looking at that outcome. So at this point, I don't really have any information about that, but maybe down the line we can have another webinar and talk about that particular question. So let me just step back for a moment and say why it's important to focus on, or why we focused on the Medicaid issue. As many of you may know, adults with mental illness who are low income and who leave correctional facilities still need access to treatment after they get out. And Medicaid coverage may be their only option in order for them to get to the medications and the counseling that they need to deal with their mental illness. But in order for many individuals who have mental illness to get to Medicaid, they first have to become eligible for federal disability benefits, that is SSI, Social Security Income, or SSDI, Social Security Disability Income. I'm sorry, SSI is Supplemental Security Income, or SSDI. And as many of you may know, there are significant application barriers to obtaining federal disability benefits, and there are often delays in coverage as a result of that. So from the big picture point of view, this program was in part trying to reduce those barriers and to make sure that individuals who were leaving prisons with mental illness who were participating in the program had Medicaid coverage so they could get the treatment they need. Couple more points about just the policy background. I think as Bob mentioned, states can't obtain what's called federal financial participation. That's the federal part of Medicaid for services provided to individuals in correctional facilities. That's just not allowed under federal Medicaid law. And as a result, most states just consider these individuals as ineligible for Medicaid. And the practice in most states has been that they won't really even accept Medicaid applications until after discharge. The problem with that is, of course, then there are some delays in actually getting Medicaid coverage. And perhaps even more importantly, if you wait until after discharge to start the whole process, that means you also have to wait until you start applications for SSI or SSDI. In general, this applications to SSI and SSDI can take a long time. The average time to decision overall is 3 to 5 months, and that doesn't include the consultative exam that is often needed, which is where a physician is brought in to do an extra exam of the individuals who are applying. And there's a lot of anecdotal evidence that adults with mental illness take actually a lot longer than 3 to 5 months to have a decision about whether they are in fact eligible for SSI or SSDI. And for some of you may know, or others may not, in order to apply for SSI or SSDI, you have to fill out consent forms. Individuals with mental illness sometimes are reluctant to fill out some of those consent forms, so they may need help around that area. You have to gather information regarding medical and functional status. That's a really important part of the disability determination application. And sometimes there's a consultative exam, as I mentioned. A physician comes in and does an extra exam on the individual, and that can, of course, delay the process even longer. So coming back now to just the evaluation design, how did we go about trying to answer those questions I mentioned earlier? We, in addition to gathering data around for the participants who were in the program, that is, the individuals who the discharge planners were, or discharge managers were working with in those 3 facilities, we also gathered information in relation to a number of comparison groups. So I'm going to just report on 2 of them here. One of the comparison groups was individuals with the same kinds of mental illness who were at the same institutions, but who were discharged in the 2 years prior to when the discharge managers began working. So that's what we call the pre-intervention comparison group. The second comparison group we call a contemporaneous comparison group because these are similar individuals, that is, inmates with roughly similar kinds of mental illnesses. They weren't exactly, is another part of the story, but I'll get to that. But these were in institutions in Oklahoma who were discharged during the same time period, but they just weren't those institutions where the 3 discharge managers were working. So they were at the same time, but in different places. And the study period, for the sake of the evaluation, was expanded from July, or spanned from July 2007 to March of 2008. The discharge managers had begun working in January of 2007 and had spent really the first 6 months doing training and getting their kind of their chops up and kind of figuring out what their new position was really all about. And then we started in July of 2007 and went through the following March. So we focused on several different measures, and this slide shows those outcomes for the 3 groups I was just talking about. There were 77 individuals in the intervention group. That is, during that period of time, the discharge managers worked with 77 individuals. Some they worked with more intensely than others for various reasons, but this is the group we defined as the intervention group. In the 2 years prior to when that program, or when the discharge managers started, at the same facilities, there were about 195 individuals with the same level of mental illness acuity. And in the similar, during the same time period, that is the contemporaneous group who were being discharged during the same time period from different institutions, there were about 130 of them during the study period. So we looked at the number of individuals who had Medicaid at discharge. I'm sorry if the numbers somehow jumped around, but the intervention group at discharge, about 25% of those 77 had Medicaid. That compares with about 8% of the pre-intervention group and 3% for the contemporaneous group. So clearly, the intervention group had a lot more, a greater percentage of the intervention group had Medicaid at discharge, and you can see that over time that number increased. So after 3 months at post-discharge, more than a third of individuals in the intervention group had Medicaid, and that similar outcome for the pre-intervention group is less than 20% and less than 10% for the contemporaneous group. So then we asked, well, okay, so they have Medicaid. Are they actually using services? And there's a lot more data here than I can report during this call, but almost within 3 months after discharge, 2/3 of the intervention group had used some Medicaid-supported services compared to about half of the pre-intervention group, and it's a little over a third of the contemporaneous group. So these figures, and I'm really just kind of skimming the surface. There's a lot more information available in our report, which I'm going to mention in just a moment. But these figures really begin to suggest that this program that Bob described was really having the effect that it was intended to have. That the discharge managers were really doing a pretty good job. I should say that we did also the kind of multivariate analyses where we adjusted for differences between the intervention and pre-intervention and contemporaneous groups because they weren't exactly the same. And these figures are still very significant, statistically significant. So we are fairly confident in the robustness of these results. Now, a couple of other things. One of the parts of the evaluation, in addition to kind of looking at hard numbers and data, we went out and talked to all of the stakeholders involved and to try to figure out, okay, what was actually the aspects of the program or the intervention that really accounted for these positive outcomes. So I've highlighted here some of the findings from that more process evaluation or implementation evaluation. And one of the things we found was that the staff, that is the discharge managers, were really dedicated. And it wasn't just the discharge managers, it was their support teams, the individuals in the agencies at the state and local level who were involved. Everybody worked really hard to make this program effective. And there was some good training. The SOAR training that Bob mentioned was mentioned numerous times as being very important to making sure those discharge managers could be effective. Also, as Bob mentioned, there were new or revised Memorandum of Understandings, MOUs, between the correctional facilities and the local SSA offices so that there could be better communication around the disability applications, and also at the state level between the Department of Corrections and the Department of Mental Health. So this is these MOUs were really very important as providing a context. In addition, the state Medicaid agency who handled the application, DHS, dropped requirement for in-person interviews for Medicaid for this group of individuals who were coming out of the state corrections facilities, and the state SSA offices and the disability determination offices created new mechanisms for flagging the applications from the correctional facilities. And this is an interesting slide because it shows some of the actual effects of those new arrangements between with SSA offices and the DD offices at the local levels. In Oklahoma, the rate of approved disability determinations during October 2007 and August 2008, not quite the overlap with the intervention period, but pretty close, was almost 90%. And this compares with the overall Oklahoma rate of about 52%. During essentially the similar time, during the time before this program was implemented. And in Oklahoma overall, about 40% in September 2008, and the national average is about 36%. So these are just figures that document that, in fact, there's a lot of that all that work really helped in enhancing the disability determination rates for individuals in this program. So, in summary, Oklahoma was, I think, very successful in designing and implementing a comprehensive mental health reentry program. As Bob has mentioned, this program focused on discharge planning for selected high-risk offenders, and while there were a lot of ongoing efforts in place, the program really was built on and strengthened those efforts through interagency collaboration. It's just a terrific example of what happens when state agencies can get together and really collaborate both at the program implementation level as well as at the evaluation and data gathering at the level. And the analyses that we've completed to date suggest that, in fact, the intervention did achieve one of its important goals, which was to significantly increase Medicaid enrollment and service use, and that the collaboration and administrative changes that other states could also implement if they chose, both at the local and the state levels, really contributed to the program's success. The report that presents this information on the evaluation and also describes the intervention itself will be available soon. It's entitled Establishing and Maintaining Medicaid Eligibility Upon Release from Public Institutions. And it will be available on the SAMHSA website. And I've given the SAMHSA website there on this slide. So in closing, I just want to thank the SAMHSA staff who were so instrumental in thinking about and developing this contract and this opportunity, Jeff Buck and Judy Tyke, and to also say thanks to the members of the Oklahoma team that really made this happen. There were a lot of folks out there that really worked very hard, and to my colleagues here at Mathematica. All of the names of these individuals are in the report, and also importantly to the steering committee. Over what was essentially a 5-year period, key members of multiple agencies in Oklahoma met on almost a monthly basis to work out various types of problems and issues, and they deserve a lot of thanks as well. So if you have questions or comments after this call, please don't hesitate to contact me or Bob. And that, I think, and this appendix is just an overview of the specific steps that were taken by the discharge managers to ensure that individuals in the program had Medicaid at release. And so that I just included for your information. There's a lot more information about that in our report, as I mentioned. So at this point, I think I'm handing the microphone over to Seth.
Thank you very much. Good afternoon, everybody. I'm going to very briefly run through 2 online tools that the Justice Center developed to really try to distill some of the information on federal benefits for policymakers and practitioners. And these 2 tools were supported by the Center for Mental Health Services and the Substance Abuse and Mental Health Services Administration. The first tool is called the Keys to Federal Benefits Access, and this is designed really for sort of top-level policymakers who are making decisions about eligibility, documentation, applications for Medicaid, SSI, and SSDI, continuity of care issues. And this tool is focused exclusively on individuals with mental illnesses returning to the community. And I'll provide the URLs for these websites again, but this is just a screenshot of the tool, and you can see the sort of 4 main focus areas broken down into quadrants there. And I'm going to just sort of simulate clicking through to the eligibility focus area. We provide sort of an overview of the recommendation and then further recommendations. We'll continue to sort of drill into the recommendation A, and this provides just a quick snapshot of the sort of information that you would see there. The second tool that we developed online is designed primarily for jail and prison case managers and provides an introduction to a variety of different federal benefits programs. And this tool does not focus exclusively on individuals with mental illnesses, but it still covers that as well. So this tool, this is a sort of screenshot of the landing page for this chart, and you can see here that the different types of federal benefits programs are broken into these tabs here, and we're looking at the cash assistance points, the different agencies that are involved. It provides sort of a blank notes field that whomever is using the tool can sort of jot down notes and save this form. And then finally, we're looking here at the housing tab, just to give you a sense of sort of the extent of the depth of information on the site. So these tools, again, are available on our Reentry Policy website, and these URLs will be included in the copy of the PowerPoint that will be available after the presentation. I think I'll turn it over to Elizabeth now for the question and answer session.
Thank you, Seth. I am going to now begin the question and answer section, and thank you so much to our presenters for a fantastic presentation. And I know I have chatted this to a bunch of people, but I just want to reiterate that these slides and the recording of this webinar are going to be available on our website at the end of this event. And so I've gotten a lot of great questions, and I'm going to do my best to answer as many as possible in the remaining time. But please do follow up with me or the speakers whose emails they gave earlier, and if your question was not answered. So the first question is about the caseload of discharge managers. Bob, I don't know if you'd like to speak to this, but there's a question about what their caseload is and the qualifications that they have.
Yeah, sure. One of the things about the discharge managers is that, and first of all, we were incredibly lucky to get the quality and caliber of individuals that we did. For the most part, it was post-baccalaureate experience. Some of the folks were working on their masters, but we made sure that there were individuals who had experience in both worlds. So they had worked in the mental health arena, but also had worked in criminal justice, so they really had a good sense of both of those. The caseloads are a little bit different. Say at the penitentiary, the caseload for the discharge manager there is probably at any given time about 20 to 25 folks that they're working with, and this is at various, folks are discharging from prison all the time, and so they're folks who are working, but the level of acuity of the individuals that she's working with, or that person would be working with, would be a little bit different. There's also at the penitentiary, there's not a social service specialist who is actually helping with a lot of the some of the behind-the-scenes work and getting the applications going, where the discharge managers at the other two have a larger caseload, but they also do have social service specialists who are working with them. The largest caseload would probably be at our Joseph Park, the men's facility, and I believe at any given time that particular one right now is working with about 45 or so folks who are kind of in the pipeline for discharge.
Okay, thank you. And then I think this question goes to Henry. With increased Medicaid utilization and the costs associated with that, is there data on the impact of these interventions on recidivism rates?
Yeah, that's a good question. We are trying to gather that information. Really, actually, Oklahoma is trying to gather that information. So we do not have at the moment good data on recidivism or reincarceration rates because, in part, there just hasn't been a long enough time span. But we are assuming that if individuals have access to mental health treatment services and actually use them, that will decrease the likelihood of them being either showing up in emergency rooms or getting reincarcerated or going into state residential treatment facilities or psychiatric hospitals. But we will do our best to test that assumption once we have the available data.
And then along those lines, Henry, there's also a question about, did you find that success rates were higher for offenders who were able to establish their benefits sooner compared to those who either had to wait for their benefits or were denied benefits?
Yes, that's, well, for the individuals who the only way they were, well, for the majority of the 77 who were participating in the intervention program, the only way they got into a Medicaid was by being approved for having disabilities. So that was their route into Medicaid coverage. And as the last slide where I showed the disability determination rate, the number of individuals who were determined disabled was substantially higher during the intervention or for that group of people that the discharge managers were working for. Now, you don't necessarily expect them all to be determined to be disabled, because in some cases they may not make or meet the standards that SSA has for disability. But presuming they do have serious mental illness and that serious enough so they really are unable to work for an extended period of time, then if you present that information in an accurate and comprehensive way to the disability determination folks, then you're likely to get them determined to be disabled, and therefore they'll get Medicaid.
If I may weigh in just real quickly, that one of the other things with that getting such a high percentage of the disability determination allowance rate has to do with the working hand in hand with our staff and their staff, so that a level of kind of institutional trust that had not previously existed was there. And really, our staff were trained in such a way, through the SOAR training, but also just through meetings with Social Security and with the DDD folks, so that we really did a thorough job of vetting folks first, so that we're not sending inappropriate referrals, and so that there was a level, like I said, of institutional trust that may not have existed prior to our collaboration.
Thanks. And the next question I have is, so has Oklahoma State Medicaid policy now changed based on this study so that offenders can be pre-applied for eligibility prior to their discharge?
Bob?
Well, policy has not changed. Really, we were able to do a pre-application process, but we just are not allowed to have basically an official approval prior to the date of discharge. Like Henry was saying, one of the things that did change, and it was more of a practice change than a policy change, was that the face-to-face, early on in our conversations, that was one of the things where we thought that we could do the pre-approval, but they would still have to actually go and show up at a Medicaid office before they could go ahead and get that approval. But now we have everything preloaded. We have the disability determination already on board, which is what the Medicaid folks need to be able to make that approval, so that they're able to essentially activate those on the day of discharge. But it was not a policy change that caused that to happen.
And can I just jump in? I think that distinction is an important one. The Medicaid agency was a full partner in the steering committee, and I think they were very dedicated to trying to create new practices that achieve the goals of the state Medicaid agency. And that's really what we were doing. It wasn't a change, in kind of Medicaid policy in Oklahoma, or necessarily even the state health plan, Medicaid plan. It was really making sure the practices worked efficiently.
Thank you. And then we have another question. Have there been any problems with completing the Medicaid pre-screen and then the inmate's release gets delayed? Is there a time frame that is best to complete the pre-screening?
Yeah, that really has turned into an issue. One of the main that could be a problem is with when there's someone who is on the parole docket. And Oklahoma is the last state in the country where the governor actually signs off on every parole, and so there's an extra administrative step that occurs there. And so we have had some issues where we've had to kind of back off on, and because we really do try to get the applications in 45 to 30 days prior to the projected release. But even in general, the releases from the general just releases in general, whether it be probation, parole, or whatever else, it's such a fluid process because individuals' days can be added or they can get achievement credits, and so it's really been it's a balancing act to try to do that, and that's why I'm trying to keep the lines of communication open. We just actually recently made a revision such that when someone is on the parole docket, if they've been approved, we actually hold off until the paperwork is going to the governor's office, and in many cases we'll actually can work with the governor's office to let them know that we have a kind of presumptive eligibility issue here, and sometimes working with the governor's office and the parole board and letting them know what the plan is can help that happen. Can help, but it's an evolving process, and that certainly can be an issue, and we just kind of at the end of the day, sometimes you just do the best you can.
Thank you. And then I have a question for Bob. Can you comment, please, more on the RIC teams and how they are related to the discharge planners?
Sure. The discharge, I'll start with the discharge managers. The discharge managers are working with individuals who are discharging throughout the entire state. The majority of our population certainly do go to Oklahoma City or the Tulsa area, those being the two major metropolitan areas. But the discharge managers are working with individuals who are going throughout the state. If they're going to one of the areas that do have the RICA teams, that's always by far the best referral. But they may be going to different parts of the state, so the discharge manager would maybe be looking at working with the community mental health center there and looking at what's the appropriate level of care for that individual, whether it be just adult case management with medication management or a PAC team. But then when the discharge managers are working with the RICA teams, they're really working in partnership with them, and they work on coordinating. First of all, there's a referral process, and so the discharge managers would make a referral directly to the RICA team, and we have a form and the documentation that we've asked them to present. And then the RICA team, because they are working with folks in the community, we do want to give them a sense of kind of entitlement in terms of making sure that they're working with individuals that they feel comfortable with. And for the most part, there's very few cases where they would not work with someone, but it was someone who was very treatment resistant, who was really not, has a tremendous history of violence or some issues like that. There may be times when the RICA team may, decline someone, but we always kind of case those to make sure that it's appropriate. But the discharge managers are coordinating with the RICA teams as they come into the facility, but then also coordinating the discharge timing so that the RICA teams are made aware of when the individual is going to be discharging, so they can really work with them in the community. And really that first 72 hours week out in the community is so important. And the RICA teams are actually working with those individuals as they discharge. They're available to those individuals 24/7 by a pager system. But they'll take the individual to their probation office for that first meeting. If need be, they'll take them by the Medicaid office and maybe get some food stamps going. They also can help them set up their payments for their court costs. Although they do have flex funds also, and the flex funds can be used for most anything except for court costs and fines and those type of things. But it is an ongoing partnership between the discharge managers and the RICA teams.
Thank you. And I think we have time for one last question, and it's very timely. What are the expectations about future changes in relaxing the restrictions against incarcerated persons with SSI or SSDI? Also, are there any predictions about future funding for those benefits?
I think I'm going to punt that question to somebody on the Obama administration. It's hard to know what's going to be coming down in the context of healthcare reform, and if there is going to be Medicaid expansion, then I think many of the rules that we're currently dealing with are going to be changed in some fundamental ways. There's also a lot of interest in changing SSA and SSA rules on disability and trying to promote more employment and therefore perhaps developing innovative ways of helping people who are seen as having a disability nonetheless get back to work, and that may also change somewhat the definition of long-term, or at least the patterns of long-term enrollment in SSI and DI. That's a pretty inadequate answer to what is an important question. But
well, I will say that I have not seen the most recent bill that just came out of Pelosi's office recently, but up until a few days ago, every one of the healthcare bill versions has, from what I understand in it, a provision to actually take out the categorical definitions, the age blind and disabled for Medicaid, and actually have it be more about like 130% of the federal poverty level, and so it will be more of a kind of moving it away from the old, kind of tied to the welfare system. And so I was recently heard someone refer to it as healthcare, not welfare. And so I'd be curious to see. But if that does go through, I know that some of the states have had concerns about their state match if there was a shift to that, but I also understand that some of the bills have taken that into consideration in changing the rate that the FNAP, the percentage that the states would pay. And if that change is made, that would be a remarkable change that would certainly benefit a lot of our individuals, not just with serious mental illness, but with all sorts of disabilities to access health care, because certainly the majority of our population would be significantly under that federal poverty level.
Well, thank you so much to our presenters, and I just wanted to conclude this webinar, and I hope everyone found it useful. And I'd like to thank you all for your attendance and participation, and I'd like to thank the Bureau of Justice Assistance for sponsoring this event, and a huge thank you to our presenters, Bob, Mann, Dr. Ireys, and Seth Prins. We will be posting a recording of this presentation on our website, www.consensusproject.org, and that will be available in a few days. And also, when you leave this event, a brief survey on the webinar will pop up on your screen, and we would very much appreciate your feedback. Thank you so much. Bye-bye.